Audio course on PET and gestational hypertension, Episode 10, Integrated Cases and Final Synthesis. This final episode is about using the language under pressure. The goal is not to recite definitions. The goal is to hear a case and immediately ask the right next question. Case 1. A 38-week patient has new blood pressure readings of 148/94 and 150/92. She has no headache, no visual symptoms, normal platelets, normal creatinine, normal liver enzymes, and no proteinuria. The fetus is reassuring. The diagnosis is gestational hypertension without severe features at term. The management is delivery, usually induction unless there is another obstetric reason. The reason is hypotat logic. At 37 weeks or beyond, continuing the pregnancy keeps accumulating maternal risk while fetal maturity benefit is small. The trap is to say, no protein, so she can wait. That is old thinking. Case 2. A 31-week patient has new gestational hypertension. Protein is negative, labs are normal, but the SFLT1 to PLGF ratio is high, and the fetus is beginning to fall across growth percentiles. This is not a patient for casual reassurance. Depending on the guideline, she may still be labeled gestational hypertension or may meet a broader uteroplacental dysfunction definition of preeclampsia. Either way, the biology is concerning. A high ratio is not diagnostic by itself, but it suggests placental anti-angiogenic disease. Growth deceleration suggests placental dysfunction. The next move is close maternal and fetal surveillance, not delivery just because the biomarker is high, and not discharge as if the case is simple. The trap is to treat biomarkers as either magic diagnosis or meaningless noise. They are neither. Case 3. A patient with chronic hypertension and baseline proteinuria presents at 29 weeks. Her BP is worsening, proteinuria has increased, creatinine is rising from baseline. Platelets are falling, but still above 100,000. This is possible superimposed preeclampsia. The diagnosis is difficult because chronic kidney disease and chronic hypertension create baseline abnormalities. You need trend, symptoms, labs, fetal growth, Doppler, and sometimes angiogenic testing. The trap is to use proteinuria alone. In chronic renal disease, proteinuria can rise during pregnancy. The more important question is whether new organ dysfunction or uteroplacental dysfunction has appeared. Case 4. A 35-week patient has preeclampsia, BP 150/96, normal platelets, normal creatinine, mildly elevated proteinuria, no symptoms, and reassuring fetal status. This is late preterm preeclampsia without severe features. The decision is nuanced. ACOG severe feature rules do not mandate delivery because severe features are absent. NICE and ISSHP discuss planned birth in this window based on risk, resources, steroids, and patient values. Phoenix teaches that planned delivery reduces maternal morbidity and severe hypertension, but increases neonatal unit admission. The teaching phrase is, delivery buys maternal safety and spends neonatal maturity. The trap is to pretend 35 weeks is the same as 37 or the same as 31. It is neither. Case 5. A patient has BP 146/92, severe right upper quadrant pain, nausea, platelets 85,000, AST and ALT more than twice normal, and LDH elevated. This is HELP syndrome, even if the blood pressure is not severe. She has a microangiopathic liver and platelet disease. The correct frame is maternal stabilization and delivery planning, not outpatient observation because the systolic BP is below 160. The trap is to let blood pressure dominate the whole diagnosis. Preeclampsia is endothelial disease. Severe organ involvement can be present without severe range BP. Case 6. A postpartum patient, day 5, returns with severe headache and BP 170 over 110. This is a postpartum hypertensive emergency until proven otherwise. Treat severe BP. Evaluate neurologic symptoms. Consider magnesium if preeclampsia with severe features or eclampsia risk is present. Check platelets, creatinine, liver enzymes, urine, and symptoms. Do not reassure her because the placenta is out. The trap is to think delivery ended the risk. Postpartum days 3 to 7 are a BP peak window. Case 7. A normotensive 32-week patient has severe fetal growth restriction, oligohydramnios, and abnormal umbilical artery Doppler. This may not be preeclampsia under ACOG if maternal hypertension is absent, but it is placental disease and belongs in the same biologic neighborhood. Under ISSHP logic, uteroplacental dysfunction is central to the hypertensive disorder framework, but hypertension remains important for the PET label. The trap is to ignore the placenta because maternal BP is normal. The fetus may be declaring placental insufficiency before the mother declares hypertension. Now, let us synthesize the course. The first anchor is the layered diagnosis. Hypertension is the entry point. Organ involvement separates isolated gestational hypertension from preeclampsia. Severe features identify maternal danger. Gestational age determines whether time is useful or harmful. The second anchor is the endothelial syndrome. Preeclampsia begins in many cases with abnormal placentation and angiogenic imbalance. SFLT1 rises, PLGF falls, endothelial health deteriorates. The endothelium explains the kidney, the liver, the platelets, the lungs, the brain, and the placenta. If you understand that, the disease stops being a memorized list. The third anchor is that proteinuria is not the master variable. Proteinuria helps diagnose preeclampsia. It does not stage severity once the diagnosis is made. Severe features, maternal trajectory, fetal status, and gestational age drive management. The fourth anchor is maternal safety. Severe BP is a stroke problem. Magnesium is a seizure prevention drug. Fluids can cause pulmonary edema. HELP can present without dramatic BP. Eclampsia requires maternal stabilization before fetal panic. The fifth anchor is delivery timing. At 37 weeks without severe features, delivery is supported by Hypotat. At 34 weeks or beyond with severe features, stabilize and deliver. Before 34 weeks, expectant management is only for carefully selected stable patients in the right center. From 34 to 36 plus 6, Phoenix teaches the trade-off. Maternal benefit, more neonatal admission. Shared decision-making when stable. The sixth anchor is postpartum risk. The placenta is delivered, but the vascular disease can persist. BP often peaks days 3 to 7. Stroke and eclampsia can occur postpartum. Renal and proteinuria follow-up matter. Long-term cardiovascular prevention is part of the diagnosis. Let us end with the full resident reflex. When a pregnant or postpartum patient has hypertension, do not ask only, is there proteinuria? Ask, is this isolated hypertension or maternal placental endothelial disease? Are there severe features? Is the fetus showing placental disease? Is gestational age making time useful or dangerous? Which catastrophe am I preventing right now? Stroke, seizure, pulmonary edema, renal failure, liver rupture, abruption, fetal compromise, or postpartum readmission? That is the point of the course. GHTN is hypertension before organ disease is documented. PET is hypertension with maternal, placental, or fetal end organ disease. Severe features and gestational age drive urgency. And every number, every medication, every delivery threshold, and every follow-up visit exists to prevent a specific clinical failure.